name is Dedrick Moulton, and I will offer thoughts on the study we just heard about from Nathan Cohen. This is a very important analysis and commentary. Clearly, the history of inclusion of racial and ethnic minorities in clinical trials has been poor. But what do we gain from this inclusion? What is actually at stake? First, when we have homogeneous trial participants, we risk production of findings that are skewed and that may in turn result in inaccurate generalizations. We fail to gain understanding of race as a biological construct when it serves as a surrogate for genetic diversity. In this context, we may fail to gain understanding of differences in inflammatory pathways among different groups, as well as efficacy, safety, pharmacokinetics of medications for different patient populations. Over the years, there have been many health advances in medicine and within the inflammatory bowel disease community. But interestingly, we see advancements that benefit select populations, but failures that occur in others. If not addressed, this imbalance creates a path for health disparities. In this context, race may serve as a surrogate for social and cultural differences between different populations of people, and within these differences are determinants that may impact health outcomes. So, inclusion should include both facets, biology, social, so that when we actually include them, we create an opportunity to improve health outcomes and close the gap on racial health disparities. But just because we acknowledge a need for underrepresented participants in clinical trials does not mean we need simply ask and we shall receive. There are many challenges and barriers that exist to improve participation of these groups. To address potential barriers and to improve engagement and recruitment of underrepresented individuals in clinical trials, we'll need to look across the spectrum of our health system for improvements. From patient factors, we need to look at medical mistrust of providers and health systems, but also address the mistrust that exists for marginalized groups regarding the clinical trials process. For providers, yes, implicit bias is significant, but it may be enhanced through pressures investigators may feel to reach patient enrollment targets that may lead to exclusion of marginalized groups. Also, it becomes important to engage racial and ethnic minorities to serve important roles in clinical trials as investigators and coordinators. From hospital and research systems, it's important to recognize differences in resource needs of potential participants, particularly for underrepresented minorities who are disproportionately found in low-income and low-resource groups. Failure to recognize lack of reliable transportation or that study activities only occur in the box, that is, during usual business hours, may actually preclude their enrollment. Again, this is an important analysis and commentary, as the authors have made efforts to lay out a path towards improving participation of underrepresented minorities in clinical trials. And with these improvements, we may move another step closer towards precision medicine in IBD.